When should a patient consider changing a therapy?
The idea of looking at when to change therapy is complex. It depends on what therapy you're on, when you started it, and maybe your last imaging, if it's, for instance, a bone lesion. If you hadn't been imaged for a while, that bone lesion may have been there, and it's hard to know. But you have to really, in a disease like myeloma, you have to integrate the lab data with the clinical picture to figure out what's going on. But I think if someone has a biochemical relapse and a clinical relapse, you'd really want to change the therapy they're on unless they just started it.
When your myeloma starts to grow again, doctors often talk about this relapse as either a biochemical relapse or a clinical relapse. The distinction between the two isn't totally clear-cut, and we will go into more depth about this in later videos, but the main idea is this. Biochemical relapse means that your myeloma markers are going up. So you might have a 25% increase in your M spike and a change in your light chains, but the disease isn't causing problems like Crab symptoms. In a clinical relapse, the disease is causing problems. The myeloma is affecting your organs, and it's probably time to start treatment. Most patients will have a biochemical relapse before a clinical relapse of their myeloma. Another thing to note is that disease progression and relapse are synonymous. Doctors often will say progression instead of relapse. Just know that progression in the context of myeloma means the exact same thing as relapse does. The disease is coming back.
And sometimes we see a biochemical relapse, the patient's asymptomatic, and I think many of us don't rely on one laboratory value, and that's sometimes why we get a constellation of labs to see if they're all getting abnormal or only one is, and then we follow them over time to see if that's a trend that's happening. Also, sometimes people may be on a maintenance therapy, and we might add something or otherwise adjust the medications.
The two main reasons to change therapies are either having significant side effects or toxicity from treatment that is persistent despite adjusting the doses or adjusting the schedule, or that the patient was responding to a treatment, but now their myeloma is clearly starting to progress, meaning the myeloma protein levels are going up, or they're developing new bone lesions, or new kidney issues, or new anemia. In that setting, then it is recommended that the treatment be altered and switched out for an alternative regimen. I think there's no absolute number that I can say is used across the board to mandate a change in treatment. The International Myeloma Working Group, which is a group of myeloma experts who meet to try to come up with consensus about recommendations for therapy and disease assessments, that group has developed definitions for progressive disease based on the percent increase in the myeloma protein. However, just because the numbers go up doesn't always mean the patient has to change therapies right away. In some patients who are having good quality of life and good disease control with minimal symptoms, we will allow a regimen to go on a little bit longer, even in the sign of biochemical progression, to get a couple more time points, a couple more months of data to see if the numbers are truly going up. However, if that trend really is continuing over time, and it is confirmed, then often we'll make a change. But I can't say that there's one absolute number that's used for every patient. I think there is some individual decision-making with each doctor and patient.
If a patient is on low-dose maintenance therapy and progressing, should they try a full dose of the same drug instead?
I think it all depends on the clinical scenario. So if they are on low dose, let's say lenalidomide maintenance therapy, and they've done well and now are noted to have a rise in the M protein or serum-free light chain suggesting a biochemical progression, but without any other associated symptoms, that is a time where you can potentially think about escalating the dose of therapy and even sometimes adding some corticosteroid therapy to that to help augment that response. And that might actually last a while longer before switching the therapy all around. However, several limitations occur with this approach. One is just the ability to tolerate a higher dose of the same medication, whether it's related to side effects that a patient may experience. A lot of times we're limited by the patient's blood count. So if they've had a stem cell transplant and they're then on maintenance therapy, sometimes we are unable to give them higher doses of the same medication. So it does limit our ability to do that in that particular scenario. I do think there are certain modifications we can make to an individual therapy that has derived, that the patient has derived some benefit from, and that could be addition of subsequent medications to that particular platform instead of just ramping up the dose of that particular drug, if you add another low intensity agent to the mix, that might actually get a better response in that particular scenario that would hopefully last a bit longer than would just a simple dose modification of what they're already on. So it really depends on the individual patient. It is something that we do in certain patients, but I think you have to think about the big picture more so than smaller modifications like that in terms of where they are in their myeloma journey and what the reasonable likelihood of a benefit they may achieve from whatever intervention that we make in that particular moment. Because a short-lived benefit doesn't necessarily get us anywhere. We are always thinking the way to maximize a particular line of therapy in this particular scenario.
What should you consider when selecting a new treatment option?
So a relapse myeloma therapy, I think, has to be extremely individualized to the patient. Some factors we look at are patient-specific factors, we look at disease-specific factors, and we also look at prior exposure to therapies when we're thinking about what the best regimen might be for an individual. So if a patient has received the initial line of therapy and has had a magnitude of benefit from that, let's say lasting 3, 4, 5 years, and at the time of their first relapse, we look to see what worked well for that patient before, and then potentially think about modifying it in a way that might be tailored to that particular individual. We also look at aggressiveness of relapse, again, whether it's a slow biochemical relapse or a more clinical relapse that may affect how we might choose our therapy going forward. We look at prior toxicities to therapy. If patients have had prior peripheral neuropathy, for example, or other toxicities, let's say related to their prior stem cell transplant, including some blood count abnormalities that may limit our ability to use certain medications or not. These are some factors that play into when we think about what the next best myeloma therapy for an individual would be. We also look at the results of their cytogenetics. So if they had a certain cytogenetic profile in the beginning, at the time of their first bone marrow biopsy, we would think about doing another bone marrow biopsy for a repeat cytogenetic analysis, because we do know certain mutations get acquired over the life of a journey of a myeloma patient. And it's important at this point, while we don't have specific targeted drugs for a particular cytogenetic abnormalities, we do know which cytogenetic abnormalities may portray a more aggressive behavior, yet prompting potential initiation of therapy that we might find the most effective right at that particular relapse. So again, to summarize, we look at patient factors, we look at disease factors, we look at prior toxicities to therapy and prior exposure to therapy, and then we also think about what has worked well for that individual patient and what the magnitude of benefit of that prior therapy was, which may signal, if things haven't changed too much, that they may derive benefit from a similar class of drugs, potentially for a lot longer with some modifications.